Hi, everyone. Welcome to our workshop today. We are going to be talking about finding real solutions for behavioral health needs in persons with dementia. We're really excited to be offering this program to you. We're thrilled to have two wonderful speakers today. We have Sue Renz, who is the Practice Associate Professor and Doctor of Nursing Practice Program and the Director of the Primary Care Program at the University of Pennsylvania School of Nursing, and Kelly Bagby, who is Vice President for Litigation for Health, Hunger, Housing, and Human Services at AARP Foundation. You can get their full bios in the session description. Just click on that and you can see them. I'm going to take 1 minute to go over some housekeeping for the session, which I know you've been hearing about the whole conference, but just want to make sure folks know about it. The slides that we're going over today, you can get the link to them in the session description as well. Use the Q&A box on the right-hand side for questions for the speakers. All attendees will be muted during the session. Don't forget that there's the chat there. You can use that to make comments or to ask for technical or logistical help throughout the session. We do have a staff person monitoring that. The session is being recorded, so the recording will be available shortly after the session and for 30 days following. You can access it through this platform. And don't forget to complete an evaluation form for the session. There's also a link to it in the session description. So I am going to turn it over to Kelly so that we have plenty of time for the program. There's going to be a great session today. And thank you so much for joining us, Sue and Kelly. I'll turn it over to you.
Thank you, Lori. So it's my great pleasure to be doing this presentation with Sue Renz. Sue and I have known and worked together for many years. And so she was, when Lori asked me to think of somebody who would be a great clinician to help explain this problem and alternatives to using drugs with people with dementia, Sue was the first person I thought of. So I'm going to start out by sort of walking through why this is such a problem and why we are trying to talk about how to recognize people, first of all, who are being given drugs inappropriately when treatment is really what they need. So if you could turn this next slide. So antipsychotic drugs, also sometimes use the psychotropic drugs, are drugs that affect mental activity. And for some people, they're entirely appropriate and life-saving. People who have mental illness, can really have their life changed and stabilized by using these drugs. But if you do not have what's known as an Axis 1 diagnosis, a mental health diagnosis, and you're being given giving these drugs to people with dementia, you can really just destroy their mental ability, their interactions on a day-to-day basis. You can change their minds sometimes in a way that cannot be changed back. So one of the things I want to talk about, and Sue's going to get into more of this because she's a doctor, there are side effects with psychotropic drugs, sometimes for everybody, but definitely for people with dementia. And they can really lower the quality of life. They can make people really less likely to eat. They can make people less likely to remember to drink. So that would cause complications with their nutrition, with their hydration. They can cause sedation and dizziness, which can cause people to fall. That can lead to people breaking bones. You can develop symptoms that are known as Parkinsonian symptoms, where you become kind of trembly and your body can move involuntarily. And that's definitely something to watch for when especially for the ombudsman and family members. If you're seeing those kind of symptoms, you need to take somebody to the doctor right away and try to evaluate whether there's a way, and Sue will talk more about this, a way to sort of address this problem and taper these drugs back out again. But there's also these drugs can accelerate someone's actual decline due to the dementia. The dementia can speed up, it seems like, and that is really where you get into this cycle, because somebody will start to decline. They go, oh, let's try a different kind of drug, or a combination of another drug. So you're adding drugs on all the time rather than evaluating, and that can really make the dementia problems much more difficult to handle. Could we go to the next slide? So antipsychotic drugs or psychotropic drugs are different categories of drugs, but I'm using them interchangeably here, probably completely inappropriately, and Sue will tell me why I shouldn't do that, but they are really, you know, different classes of drugs. But there are 10 different atypical antipsychotic drugs that are used to treat schizophrenia and or bipolar disorders. And so those are drugs that are approved for that purpose. These drugs are not approved to be used with people with dementia. In fact, can you go to the next slide, Lori? In fact, these drugs have what's known as a black box warning. And black box warning is the highest degree of warning that the FDA will put on a drug. And it literally they put a black box around the warning. It's like literally a written black box. But most of the people who are dispensing drugs in a nursing facility don't see the labels. The drugs are distributed by the pharmacist, and it come out on a tray, as you've probably all seen, and they're ready to be just given to the person, given to the people on the floor, but they're not. So this packet insert is not actually seen by most of the people who are administering the drugs. So, and I've taken depositions of doctors who didn't even realize that these drugs have a black box warning, which is kind of terrifying if you're prescribing them. Can we go to the next slide? So this is a list from the FDA of the drugs with their name brand as well as their generic brand. And I believe that Lori's folks have an insert that they can distribute, that people can just carry with them in their bag or in their briefcase or on their notebook, to just know that these are the drugs you want to be watchful of. You know, there's some of them, like there are that are not listed here that are also have dangerous impact. But so we had a case recently where Geodan, the fourth one down here, was given, and the gentleman who was given the Geodan, when his family said you must take him off, they cut it cold turkey, and that was when he started shifting, and he was shifting so much, and he was rubbing his feet on the ground from his wheelchair, that he literally wore the skin right off of his feet, because that's how much he was so agitated with the abrupt stopping of the Geodan. So these things need to be addressed in a way. You don't want to just say, take them off right now. They have to be addressed in a way that is carefully and watchfully done with physician supervision. Go to the next slide. So, for example, here's the warning label for Geodan. Geodan says elderly patients with dementia-related psychosis or psychosis treated with an antipsychotic drug are at an increased risk of death. So that's pretty serious, increased risk of death. And it's actually about a 5-fold risk of death. So it's quite an extensive risk of death. And when you look, I've talked to so many experts over the years about this, but one of the experts that we worked with was pointing out to me that the study, I think it's maybe the Resveratrol study, when they look at the folks that they were evaluating, they were actually like people who are maybe 60 to 65. So imagine if you've got a person with dementia who's 85, and they are having even more complications from these drugs, because they're dealing with other consequences of health problems as they got older. The Seroquel warning is very similar and indicates that this is just simply not approved for elderly patients with dementia-related psychosis. So that's something interesting to see. I've had cases where the diagnosis overnight went from dementia to dementia-related psychosis, and then suddenly the drug started. It was actually a Seroquel, a person given Seroquel. So you do have to watch for diagnosis changes, because that sometimes you see that as a precursor to when the drugs are started, because that should not happen. You shouldn't, somebody doesn't just suddenly become, well, they certainly aren't going to become schizophrenic for the first time late, in their 80s. But the word psychosis, if it's never been used for to describe a resident, you shouldn't just have all of a sudden emerged psychosis diagnosis. That should send off alarm bells, and you should ask people, where did that come from? What manifestations of psychosis did you see? And families should ask those questions, as well as staff in nursing facilities, but certainly ombudsmen. Next slide. So a lot of people I talk to about this sort of doubt this, because they say, why would this happen? Why would doctors do this? Why would nursing facilities be giving these drugs if they have a black box warning? It just seems inconceivable. It seems so dangerous and irresponsible. But the reason is, in my estimation, other people might have other reasons, but in my estimation, it's very, very effective off-label promotion of these drugs to these populations. And I actually met Sue Renz when she and I worked for the federal government, and she was one of our nurse investigators. And when you deal with some of these companies that are really invested in profit and healthcare, and but really profit, the way that you make the most profit is you push things into vulnerable people's lives. And so, for example, and I'm going to talk to you about some of these off-label cases that kind of led to this wide proliferation of drugs in these nursing facilities. These drugs are given to, and again, Sue is going to talk more about this, but they're given to control what is seen as unwanted or challenging behaviors. And it's challenging. The reason they're challenging is because it requires more staff. Because if somebody's acting out, seemingly acting out from the perspective of a nursing facility, they're maybe trying to take care of so many different people. The staff are, they've got somebody over here who it needs to be taken to the cafeteria. There's somebody over here that needs to have meds administered. Somebody over here needs wound care. Somebody over here. And then somebody's wandering over and wanting to talk incessantly to the nurse and wants attention and wants to get, basically divert the nurse or the CNA from what it is they were doing. That, from the staff's perspective, is something that they're going, well, she's just being way too demanding. I need something. She's too agitated. She's anxious. She's this, she's that. So maybe she's sick. Maybe she's got an underlying health condition and she's seeking attention because she doesn't know how to tell you what it is that's actually wrong, that she feels nauseous, or she feels like her stomach really hurts, or she's really dizzy because of something else that's happened. But so unfortunately, it might be that the staff are trying to solve a problem that they don't know what the problem is, and the drug is an antidote to the problem, and that can lead to terrible consequences for real people. A case that we had not that long ago, we had problems where this gentleman was having an argument with another resident, and they had a tension between them, but it's not clear what the tension was really from. And it turned out that our client had a really bad urinary tract infection, and it was making him really grumpy. And so, but nobody bothered to try to figure out, were his symptoms actually something medical, or was it just that he was being grumpy and difficult? And he was really sick. And so when they finally got him to the hospital and realized he had a urinary tract infection, that kind of changed things, or should have changed things. And they should have looked carefully at what they had been doing. But by then he was already on like 3 different antipsychotic drugs. And that's, then they added more drugs when he went to the hospital for the UTI. So that these things tend to kind of become more complicated as people try to seemingly solve a problem, but they actually are worsening a problem. Go to the next slide. All right, and so these are some of how the story has unfolded. There's a case in 2016 against the federal government against Omnicare, and this was not the first case against Omnicare. There have been multiple cases against Omnicare, but Omnicare is a very, very popular nursing facility pharmacy company, and they were accepting kickbacks from Abbott Labs. Now, Abbott Labs is the maker of many different drugs, but I think this one was related to Depakote. And so Depakote, while it is not a antipsychotic drug, it's a drug commonly used for seizures. It is used the same way as some of these other antipsychotic drugs are used. And it was causing people with dementia to become very, very ill and die. Many people died. So the government brings this case. They settle it for $28 million to resolve these kickbacks. Now, this is, if you don't know what a kickback is, it's, we kind of think of it in commonsensical terms, but kickback is when Abbott is giving something of value to Omnicare, and in return, Omnicare is heavily promoting the use of Depakote in the nursing facilities they work on. So if a doctor comes forward and says, well, this person has this problem, and then Omnicare would be like, hey, you know what, you should try Depakote. I'm a pharmacist, you should try Depakote. And that's the way that they were proliferating the use of Depakote in many of these nursing facilities. Next slide, please. So then on the other side, the kickback is always two sides, right? So the kickback on Omnicare, they got 28 million. Abbott had to pay $1.5 billion for promoting Depakote to be used with people with dementia. They were actively advocating that Depakote be used in nursing facilities with people who have dementia. And it's kind of stunning to me that they got away with it for as long as they did. But even $1.5 billion is the cost of doing business for a company like Abbott. You just have to assume how much they actually made doing this. But so it is the process. It's, when you think of it, and maybe this is me being a jaded former government lawyer, but when you think about how much energy they spent doing the promotion, they knew very well that they would be successful getting Depakote to be used in a very prolific way. And they were right, and they did. Next slide, please. So here's another one, Johnson & Johnson. They actually took a guilty plea for promoting risperidol to treat dementia-related behaviors while downplaying the deadly risks of risperidol with people who have dementia. And theirs was $2.2 billion. I mean, really, that you'd think would induce meaningful change, and yet it's the cost of doing business, and they must have made a fortune doing this. Eli Lilly also took a criminal plea and paid $1.45 billion to resolve cases alleging off-label promotion of Apraxia, another very commonly used drug. And we had a case that we settled a couple of years ago, and this lovely, lovely woman who is a teacher, had raised her children, had loads of grandchildren, loved to work, loved trivia, was super smart, totally on her game. Again, she got a UTI in this facility, and rather than ever evaluating what her medical issues were, they started her on Apraxia. And within a week and a half, she had deteriorated to the point that her family didn't even recognize her. A week and a half. And so these things can work depending on your body chemistry. These things can work very, very quickly to bring your clinical abilities down. Next slide. So we're going to talk more about non-pharmacological interventions. And again, first thing that should always be done is assess the scope and severity of the behavior. Try to figure out, is this something environmental? Is it too noisy here? Is there just confusion? Is the person ill? Are they, do they have our client who had the UTI that got the Apraxia, she had just come out of the hospital with an impaction. So you'd think that somebody would wonder, maybe she's still ill, but they didn't. They just went right for the drugs. And drugs should be only used when non-pharmacological attempts have been tried and failed, but they have to be tried. And I think sometimes in nursing facilities, drugs are the first things that are tried instead of the last things that are tried. And obviously there are exceptions under most state laws about if people pose a threat to themselves or others, but there are procedures that need to be followed if that is the case. And if you can't just glean that somebody's a danger, there should be procedures followed to document that you've tried to evaluate this, that they actually are a threat, and these are not psychiatric hospitals. Nursing homes are not psychiatric hospitals. Next slide, please. So I want to just talk for a minute about who decides about these drugs. There should always be informed consent, and informed consent has to be given in the context of what you're proposing. Informed consent. If I'm going to give Sue a drug that might kill her, then the informed consent conversation is, I understand that this might kill you, but the risks are great, but this is the benefits. You have to literally lay out what the possible consequences are. You cannot just say, I want to give you this because it'll help you to stop yelling. Next slide, please. And finally, I'm just going to finish up with a case we brought many years ago. Next slide. Levine versus Convalescent Hospital in California. This is a class action we brought in California with two wonderful lawyers out there. And Ms. Levine basically had she just was perfectly normal behavior. She was in the nursing home for rehab. They gave her these drugs. They gave apparently everybody in the nursing facility these drugs. And she, within a week, she was unrecognizable. Next slide. The daughter took her out of the nursing facility and took her to the hospital, and within a week she was dead. And so she came to us and we filed the lawsuit, and when we resolved the case, there's a 2014 bulletin article about this, and when this ran in the bulletin, we got hundreds and hundreds of phone calls of people saying, this is what happened to my mom. And so this is why we've been fighting these cases as hard as we have ever since. And I'm going to turn it over to the real expert here. Can you just push the slides down to Suze? Thank you.
Thanks, Kelly. Let's go to the next. I really like the title of this session because it's really near and dear to my heart too. And I just, in addition to being an academic, I am a geriatric nurse practitioner and have been in practice for over 32 years now, with the focus of my practice being on long-term care, caring for older adults in adult daycares, nursing homes, assisted livings. And so I'm very familiar with this problem that we're talking about today. And when I teach my nurse practitioner students, one of the things that I emphasize in talking about kind of the care environment is really being mindful about how they're prescribing psychotropic meds. And Kelly, you were right. Psychotropics is kind of the broad term for medications that we prescribe for, behavioral mood issues. Antipsychotics being kind of a subclass of that. But it's important, whether you're a clinician or a lay person, to understand that clinicians need to take prescribing very seriously, and that when we prescribe medications, it's based on assessment, and it's based on the result of an assessment, some type of finding that really warrants the use of medication. I think, this slide really, these are statistics that are from 2017, actually. When you look at the percentage of people who have dementia in various care settings, these statistics really haven't changed significantly over the years. But when I began practice in the 80s, it wouldn't be unusual to see more than 50% of a resident population within a nursing home medicated somehow with some type of psychotropic, and particularly antipsychotics. And just to give you some context, back in the 80s, even when OBRA came into play in 1987, nursing homes weren't really tightly regulated, and clinicians were never questioned about prescribing practices. So if you had a resident that had a mood issue, somebody who was talking too much, somebody who was wandering, restless, anxious, calling out, resisting care, and I'll talk more about this in a minute, oftentimes the result of the assessment of that behavior was that these are symptoms that needed to be medicated. Call is made to a clinician, and the most popular drug probably in the late 80s, early 90s was Haldol, and no one would have questioned whether or not we put someone on an antipsychotic to try to extinguish those behaviors that I just outlined. And this is really the crux of what we're talking about today, because we no longer are allowed to do that, thank goodness, and that nursing homes are more tightly scrutinized and regulated to make sure that there is hopefully an assessment process in place to figure out, what is the mood, what is the symptom that the resident is exhibiting, and is medication really necessary? Now, I should say that while we have made some progress, as Kelly pointed out, there's still a problem in that the last person to be questioned about the prescribing of a medication is a clinician. We are the least challenged in terms of clinical decision making, and yet we should be held accountable for when we're asked to prescribe a medication to make sure that there is an indication for it, and more importantly, that there's a process for follow-up and reassessment of the need for that medication. So anyway, this first slide really is just to show you that, dementia and problems with cognition are pretty prevalent in the long-term care setting with about 50% of nursing home residents. Next slide, please. And what I want to outline too is that what we're talking about today is we're medicating people for what we call behaviors or psychological symptoms that are associated with dementia. So, psychosis is one of them, but there are also other symptoms that people present with that are often medicated. What I want the audience to understand is that when we're talking about that, we're talking about, that people with dementia, because they have frontal lobe damage and, in various stages, have disturbed perceptions, of their environment, what it looks like, what people are saying to them, what a caregiver is trying to do. And so there's a disturbance in the thought process and thought content, and sometimes mood and behavior. It is, often if you see someone with dementia where they don't have any mood issues, you're pretty lucky, because a large proportion of nursing home residents in particular do have some mood issues associated with it. And someone in the question and answer box there did point out, and I've seen this too, that we've seen a rise in some of these mood or behavior issues with the pandemic because of nursing home residents being socially isolated in their rooms because of the need for social distancing, and also with the decrease in activity related to that social isolation. So as I said, this statistic's pretty high, but 90% of patients with dementia sometimes we'll have one type of mood disturbance. It does impact the caregiver burden, whether it's spouses or children caring for older adults in the home or in a care environment. And these behaviors that people exhibit, and even that Kelly pointed out, cause, distress, not only to the caregiver, but it actually causes distress to the individual themselves. And you can see why, because of that, and because of the high incidence that has led to an over-prescribing of medications in the absence of really a true clinical syndrome that needs to be medicated. We know that the use of psychotropic meds and the overuse or the overprescribing has led to admission to long-term care institutions because of that example that you pointed out, Kelly, at the end of your presentation, where it can create problems with the individual, where their cognition is impaired, they've lost function, they can't eat, they've become incontinent, all from the medications requiring long-term care admission. Next slide, please. So think about this, when you think about some of the behavioral and psychological symptoms of dementia, these are think about how does memory impairment lead to a behavioral issue? Well, here's an example. A resident or a patient is not able to dress himself because they can't remember, where his clothes are kept, right? Because the association with a closet or a dresser is lost. And so that person walks around naked, which to most of us who understand dementia is understandable because of the loss of brain function. But to other people, they might see that behavior, someone walking around naked, as a problem that they want to extinguish. And so it might lead to, the prescription of an antipsychotic with the hope of trying to ameliorate that symptom, when in fact we know that it doesn't do that. Next slide. Again, impaired recognition. So that's a term, a technical term called agnosia, where a person doesn't recognize objects that are familiar to them when they don't have memory impairment. So an example is someone can't maneuver to use the bathroom. They can't maneuver to pull their pants down because they don't recognize that a toilet is a receptacle for urination, something that we automatically do in our everyday lives. But people with dementia don't look at a toilet and all the time and think that that is what it's used for. And so they urinate on the floor. That's a problem behavior, and often seen in nursing homes where people urinate in various places. Again, that could trigger the use of a medication to try to extinguish that behavior, when in fact a medication isn't going to do anything related to that particular symptom. Next slide. And the last is the performance of motor tasks, which we call apraxia, when there's an impairment there. So a person is continent, but they can't unzip or unbutton to pull down their pants, and so they wet their clothing, they're incontinent, leads to staff frustration. Maybe they, instead of helping the resident with this, they automatically put a brief or a diaper on them, which leads to maybe a behavior issue because the resident doesn't want to wear a brief. Again, down the road could lead to the overuse of medication. Next slide. So these are some of the behaviors that I described, a few of them earlier, that I want you to think about. You hear often and many times when families are called about their loved one having a behavior, the behaviors that are described can encompass, physical and verbal, such as, they're restless, they're wandering and pacing, they're hitting, scratching, and biting, resisting care, they're throwing things, they're socially inappropriate, they're making sexual advances on other residents, they're screaming or cursing, or they're having a temper outburst. Or a psychological symptom that is different than the person's baseline, where they have now new symptoms of depression or anxiety. They're apathetic to their mood. You know, they're just not as initiated or engaged. They have sleep disturbances, and then often, sometimes people with dementia, often in the later stages, show signs of psychosis, where they're hallucinating, they're seeing things that are not there, or they're delusional. These are all behaviors that, again, have led to the overprescribing of psychotropic meds that really require, most important point of today, is really require an assessment about what is actually going on. Next slide. And so the most important thing that I teach my students and when I'm mentoring in the clinical setting is that all behaviors have a root cause. So all behaviors have meaning. Many of you have probably heard that before. I would encourage, family members to ask when they're getting that phone call about, my mom is restless, your mom is restless, or they're wandering and pacing, is to ask the question of why. What's different? Is there something going on? And so it is so important to really ask for the staff in any facility and the clinicians to try to identify what's going on. What's the underlying cause of the agitation or aggression? And I really, to be honest with you, I don't like the word agitated or agitation. My colleague that I worked with Kelly many years ago, we used to always say that the person's upset. Something is, instead of saying agitated, which I think is pretty pejorative, it's really a derogatory term. It's more that they're upset. Something is triggering a behavior that we really need to look for the root cause. So some of the reasons that people have changes in behavior, they're experiencing a delirium. It might be a medication side effect. It could be that they have a sensory deficit. They can't hear. Their vision is impaired, something like that. They might not be able to express themselves because they have advanced cognition deficit, a cognitive deficit, or language deficit. They can't put the words to what they want to say, what they want to ask for. They have unresolved pain. They're not sleeping well, and many of us can attest to the fact that if you don't have a good night's sleep, what that actually does to your overall sense of well-being and your mood. Some people are experiencing depression or anxiety or apathy and psychosis. They have an unmet need. They're hungry. They're tired. They need to go to the bathroom. They need to get up and move. So they have an unmet need, and there might be an environmental trigger, like they don't like the person at their table. It's cold in the environment, too much noise, the lights are on, staff are screaming at them. There could be so many issues, but key here is really to identify what is going on that is creating this response, this mood change. Next slide. And so the first thing really, in addition to really looking for the root cause, is if there is going to be some type of intervention, and there really should be, it's really looking first towards non-pharmacological management. The studies have shown that not using meds has been shown to really reduce agitation and anxiety in people with dementia. And that those techniques that are used to help kind of reduce, take the person down, get their anxiety down, needs to be individualized. What's actually going on with that person that we really need to address. And non-pharmacological interventions really incorporate, three kind of buckets. One is behavioral interventions. The other is caregiver education and training. And here, I'm really talking about education and training of nursing home staff or assisted living staff, where they really understand this is how you address or deal with somebody when they're having a mood issue and they have advanced dementia. This is how you approach them. This is how you should talk to them. Sometimes just using touch or no touch at all. And then incorporating other sensory techniques. It can help actually reduce agitation or upsetness and anxiety without the use of medications. Next slide. So the other thing is to think about what is triggering the behavior in that individual and to avoid those triggers. So people respond better when they have a consistent routine and environment, when there's predictability to it, and when it's individualized. So if I am ever in a nursing home, I get up at 5 o'clock in the morning, and I hope that that routine would be honored if I'm ever a resident in a long-term care setting, or someone who's worked night shift all their life. Like really that the environment is really tailored towards that individual's needs. And to avoid, sudden changes in routine that can really precipitate increased confusion and then subsequently the agitation. Somebody's used to a shower at a certain time of day, or if it's a trigger for someone to have, lukewarm water versus hot water, all those kinds of things that really would upset us as individuals, really making sure that we avoid those triggers in people with cognitive loss. Determine and anticipate unmet needs. So if someone has pain, to make sure that they're on a routine, that their pain is addressed and that they're on a routine regimen to address, chronic pain. Are they hungry or thirsty? And then also to really incorporate, appropriate language that can actually facilitate communication. Cognitive deficits can't respond to conversation like we're having today. It might be simple cues like, come with me. Are you hot? Are you hungry? Or just, nonverbal behavior. Cues for someone so that it helps facilitate communication. And the last bullet's really important. I'm sure all of you have heard about person-centered care. To me, what that means is really looking at the individual. There's not one plan that works for everyone who has some behavioral symptom related to dementia. It really is based on that individual. And it is important to incorporate what the family knows about that resident that can actually help them if they're exhibiting behavior. Some things that I have found very valuable information from spouses and children that said, hey, when dad was upset when he was younger, this is what we did. It's so important to incorporate what we know has worked in the past and what the family can bring to the table. Next slide. I talked about a little bit about, caregiver education, communication skills training is so important. Provide a calm, reassuring communication when that resident seems anxious, and use redirection and distraction techniques. If the person is taking them to the shower and it's not the right time to take a shower, the appropriate thing to do is to try it again later. Engage in an activity that's creating anxiety to begin with. Next slide. And then, incorporating other sensory techniques that we know actually do help in the long-term care environment, using aromatherapy, music therapy, massage, and touch if appropriate. Exercise, can't underestimate and overemphasize the impact of exercise and activity on reducing anxiety and agitation. And then pet therapy as well. These are all easy interventions that facilities should incorporate, obviously, before they consider a medication. Next slide. I like the term or the phrase correct the correctable. So when I spoke earlier about looking for root cause, correct the correctable. If there's an infection, Kelly mentioned a situation where somebody had a urinary tract infection, then correct that. Treat it. If someone has pain, treat it. If someone needs to move, get them up and move them. If they're hungry, feed them. If they're diabetic and their blood sugar dropping too low is really what precipitates a behavior, make sure it doesn't drop too low. Monitor that person closely. Can't say enough about stopping non-essential medications. This is something families should ask about all the time, to look for drug interactions. Is there some drug toxicity, some other medication the person is taking, or some drug-to-drug interaction that is really causing this change in behavior? always should look at medications and reduce them. Reduce psychiatric symptoms, and sometimes that is, it is necessary to treat with other types of psychotropic meds to reduce the psychiatric symptoms, like treating depression. Provide structure and emotional support and maintain function. Keep people, get them out of the rooms, get them out of their beds. Next slide, please. So I do want to mention, and just to dovetail on what Kelly was talking about, sometimes medications are needed. And usually, you know, antipsychotics are, in my opinion, really the last resort in terms of there's many medications that can be used to treat anxiety and even psychosis. And we don't have to resort to antipsychotics. We do know, as Kelly pointed out, there are black box warnings that providers and pharmacists should know about. There is increased use of these medications, especially with people with dementia, the risk of stroke or myocardial infarction and even death. Again, reserve these meds for symptoms that are really severe. Like, is it really causing the person extreme distress and really imposing or preventing them from functioning, or does it pose a safety risk? So is the behavior posing a risk to the person themselves or to those in their environment? Agitation and aggression that is not managed through any of those other interventions that I already spoke about, and psychosis that is debilitating. So someone believing that they see someone in their environment that's not there, or that they're talking to someone that's not there, or they call you mother when you're not their mother. That's not a problem. That's expected sometimes with people with cognitive loss. That is not a reason to medicate people. And, you know, antipsychotics really should not be used routinely. And key point here is that if they are prescribed, that they should be regularly reassessed. There should be a time frame for when that medication should be used. One example is if a resident goes to the hospital and has an infection and they develop a delirium, which is a temporary, time-limited exacerbation or increase in a level of confusion. Sometimes when they're hospitalized, they will be treated with antipsychotics. When they come back to the nursing home staff are required to really reassess, is this medication really needed? Is this related to this hospitalization and this acute infection? It is their job to make sure that the medication isn't continued indefinitely. And that is something that I routinely do in my practice. And I think that all families should ask the physicians and nurse practitioners that are taking care of their loved ones to really reassess the need for an ongoing use of an antipsychotic. And really, you know, there's no clear evidence indicating the benefit of the first generation antipsychotics in dementia. So the first generation antipsychotics, as opposed to the newer ones, are the ones that really caused or really have potential to cause some of those side effects that Kelly outlined earlier, especially tardive dyskinesia, those Parkinsonian symptoms that people get as a side effect from using these medications. Next slide. So I said, you know, if you get a call that, you know, they're going to order Apraxia or Risperdal or Geodan or whatever, I would want to make sure that, you know, there's a clear description of the need, that the behavior, it poses a danger to that individual or others, that they have uncontrolled agitation despite all those non-pharmacological interventions, that there's anxiety or, you know, unrelieved anxiety in the presence of agitation or hallucinations. And, you know, there might be a temporary need to decrease the agitation for diagnostic, you know, a test that the person needs to have, or some other type of clinical intervention. Again, even in these scenarios here, time limited, and really the need for reassessment, you know, as to the ongoing need for the medication. Next slide. Kelly talked about the FDA warning, you know, the black box warnings. We do know that antipsychotics, as well as other medications, increase the risk for somnolence. So I want to just outline here that when I mentioned earlier in my presentation that these meds were used widely in the early 80s, all they do for people with dementia, they don't cure any symptom. They don't change the brain chemistry. They merely sedate. And so it is expected that if you're going to give someone an antipsychotic or a benzodiazepine like Ativan or whatnot, you're going to cause sedation. It suppresses the central nervous system. So people who are on these medications have an increase of falls and fractures because they're somnolent, they're sleepy. They also have risk for postural hypotension, which means that they stand up, their blood pressure drops, and they have an increased risk for falls. And that they can have motor and sensory instability as a result of the use of these medications. So again, these individuals are at risk for falls and other related types of injuries when initiating antipsychotics, and then if they're used for long-term use. Just should, again, always be reevaluated. Next slide. And so, just in summary, we do know that there's a wide range of behavioral or psychological symptoms that people might present with dementia. And as dementia progresses, sometimes the potential for these symptoms to occur is going to increase, and expect them. It is important to really identify what is going on. What do they think is causing this increase in agitation and aggression? The symptoms might be related to either an acute or chronic illness, and which really should be evaluated. Many of those symptoms that I described can be managed by use of non-pharmacological methods, and there's so many that should be tried first. And caregiver education. Antipsychotics reserved, when safety really is an issue. Always question if they're going to order one, what is the symptom that they're trying to ameliorate, and what's the plan for tapering the person off. It is a requirement in nursing homes to do what we call a GDR, gradual dose reduction, every 6 months. And that's usually triggered by the pharmacist, looking at the drug regimen to suggest that to a provider. I would hope that providers do that before someone tells them that they need to do it, because it should always be a clue when you're looking at a resident's med list that anyone on any antipsychotic should be reevaluated, and that they really should not be used routinely. There are so many other medications that can be used if a person has depression or anxiety that are much safer and really have a far less risk of, side effects, decreased function, and even death. Thank you.
And thank you, Sue and Kelly. What an excellent presentation. So much useful information from both of you. And I just want to, as we're getting ready to queue up the questions, just remind our audience that we have this campaign with AARP Foundation, Avoiding Drugs Used as Chemical Restraints, where we are working to educate consumers about the things that we've been talking about today, about the proper treatments for people, about the dangers of these drugs, and that there are alternatives that you should be asking for, and that you have rights, that you should not just be prescribed these drugs without consent. They should not be used without looking at other alternatives, and they should also not be used for any prolonged period of time. So we've got a lot of information that we've been creating and linking to on our website, and you can get it at this particular site. And I actually had put a couple different examples of resources in this slide, and they didn't come out, but so we'll double check that and post it on under the description. But we've got a number of resources, fact sheets. We have the drug card, as Kelly had mentioned. You could just slip it in your pocket, and it has questions that you should be asking staff if you have concerns about the drugs, as well as the list of antipsychotics that Kelly had put up earlier. And we started a podcast earlier this year as another form of getting out to reach people. It's called Pursuing Quality Long-Term Care. You can get editions on our website as well as from iTunes and on SoundCloud. So we have a few minutes left. We've got a couple questions that maybe we can ask, and then if y'all have any other comments, we can go to those as well. So one question that came in is, are there laws in place to make it mandatory for doctors and pharmacists to know about the black box warnings? Shouldn't we be holding them accountable for that?
Sue, do you want to take that one?
Well, I guess, Kelly, you can speak about the law, but I think from a clinical perspective in our training, it is definitely good clinical practice, and within our standards of practice to understand and to be held accountable for the medications that we prescribe. So I think clinicians, nurse practitioners, and physicians definitely can be held accountable because they're the prescribers. I think the pharmacists are pretty good, at least in my practice, with pointing out when there's potential for drug-to-drug interactions, or reminding us if we're prescribing something that has an associated black box warning, or when someone's been on an antipsychotic longer than expected. So, we as prescribers are definitely and should be held accountable.
And there definitely are laws on the books requiring particular pharmacists have to look. It's part of the federal law that pharmacists have to evaluate side effects, and it's part of state law and states' licenses that doctors should not be prescribing things that they don't know what the side effects are or the consequences are. Lori, do you want to answer Becky's got a question? I believe, Becky, the answer to your question is that Becky's asking if the consumer voices resources apply to non-facility settings, and they're universal to anybody that's facing the use of these drugs with a person with dementia. That's all the same consequences.
Yeah, absolutely. And I think all of the materials that we have apply directly just across the board to anyone who may be at risk for being prescribed these drugs and can be used with anyone. Certainly there are some additional protections for people living in nursing homes that would kick in for people in that setting, but the resources do apply to everyone. And there is a question about whether fines can be increased to a point where the drug companies are disincentivized from promoting the drug's use. What do you think about that, Kelly?
I mean, like, how much over $1 billion or $2 billion do you need to go for the drug companies to be disincentivized? I mean, I think it really is a function of it just needs, we all need to be educated, and we all need to make sure that we're asking questions. I think only if we're an army of question askers will this behavior change. I don't know where's the magic point, 10 billion? I mean, I think that if we have the control by asking questions and pointing out what's right and what's wrong, and that's, I think, the only way to really push back on this.
Yeah, absolutely. I mean, I certainly would agree with that, and think that as families are demanding better options and better care, that we will get to the changes, and certainly, encouraging people to not just raise the questions that were talked about today, but also work with your ombudsman programs and file complaints with your licensing agency as well, to, again, just continue to draw awareness, as we need better accountability for facilities that are not being held accountable right now. Absolutely.
Can I just add one thing that I just want to emphasize something, I forgot to do this, that Kelly mentioned in her presentation, and that was the diagnosis. The way around prescribing early in the 90s was that everyone with dementia suddenly had a dementia with psychosis diagnosis on their chart. And so regulators, surveyors coming in would never question that. It was like, okay, you got dementia with psychosis, Haldol is okay then. I would really hope that families and advocates really press a little harder than that, because just putting a label on someone requires an assessment. And so whether it's an assessment by a primary care provider or a psych NP or psychiatrist, to really, really document that based on assessment, this person is exhibiting these symptoms that warrant a medication. In the absence of that, there's really no justification for the medications. I also think that someone had asked a question about, referring to, sending people out for a hospital admission or even referring to psychiatry. I guarantee you that if a nursing home resident is seen by a psychiatrist, there's going to be a medication that's recommended. Again, knowing what is the targeted symptom, what are we treating, for how long, and what is the expectation of that medication, the pharmacological treatment. That's what's important to know. And clinicians need to educate families about that. Like we would be having that discussion with a clinician ourselves if it were us or someone in our family. And that's what should be provided for nursing home and assisted living residents as well.
Absolutely. Well, we're at the end of our time for today, and I would like to thank Sue and Kelly for such a great range of information that you've shared with folks today. The questions that we're encouraging you to ask, even now during COVID, you should be asking those questions. If you have concerns about what you're seeing with your loved one through video chat, or if you've been able to go back in and visit, if you have concerns about the care that they're getting, ask the questions, ask to see what medications that they're on, and raise those concerns with the staff and ask for assessment and care planning processes to be done. It's really important that that happen. So thank you so much to both of you. Thanks for joining us today. Please fill out the evaluation for this form, and you can get the slides, as I mentioned, under the session description, and look forward to continuing to work with you both on this issue. Have a good rest of the day. Thanks.
Bye.
Thank you.